Hello, welcome to the ASGE video tip of the week. I'm Dr. Chris Thompson from Brigham and Women's Hospital, and I'm here with Dr. Allison Schulman, our fourth-year advanced endoscopy fellow, and she's going to present a case of a patient with abdominal pain and weight regain after gastric bypass. And this is a fairly typical presentation for this particular condition.
So this is a 29-year-old male who underwent gastric bypass surgery when he was in his early 20s. He did well for several years. However, over the past 3 years, he started to notice significant weight regain. He regained the majority of the weight that he had initially lost with the surgery. And over the past 2 to 3 weeks, he started to notice significant abdominal pain. He presented to see us in clinic, and we scheduled him for an upper endoscopy.
Here, the endoscope is being passed down the esophagus into the small gastric pouch. As we continue to pass distally, we would expect to see the gastrojejunal anastomosis and enter the Roux limb. However, rugal folds become apparent, and it appears that we have entered the gastric remnant, suggesting that we have passed through a gastric fistula. Close examination of the proximal portion of the remnant demonstrates a stenotic and ulcerated gastrojejunal anastomosis. Significant pressure is avoided, however, given the ulcerated appearance and the concern for causing a perforation. The endoscope is eventually passed into the Roux limb, where the mucosa appears normal. On withdrawal, we can again see the ulcerated mucosa on the jejunal aspect of the gastrojejunal anastomosis. The remnant stomach and duodenum are also closely examined. The mucosa appears normal, and no additional ulcers are visualized. Additionally, there are no polyps, lesions, or any other concerning findings. The endoscope is ultimately withdrawn.
A gastric fistula is an abnormal connection between the gastric pouch and the gastric remnant. And this can form for a variety of reasons. It can be due to a breakdown in the staple line. It can be due to ulceration that erodes from the pouch into the gastric remnant. It can be due to inflammation. These can form due to a variety of mechanisms. Symptoms typically include abdominal pain, nausea, vomiting. They can have reflux type symptoms as well. And weight regain is very common in these patients. Additionally, ulcer formation can be seen at the gastrojejunal anastomosis and oftentimes at the jejunal side of the anastomosis as these areas are now exposed to more acid production from the gastric remnant. Diagnosis of a gastric fistula is typically made on upper endoscopy or upper GI series. And here you see on the left a classic image of an upper endoscopy with the pouch on the right and the fistula on the left going from the pouch to the gastric remnant. And on the right of the slide you see an upper GI series illustrating contrast spilling from the gastric pouch into the remnant. And these are very typical findings. It's also important to note that on upper endoscopy you should always retroflex in the pouch to see if there's a proximal fistula, because oftentimes the breakdown of the staple line will occur in that gastric cardia. So it's important to include that in the evaluation. Additionally, CT scans, MRIs, small bowel follow-throughs can be helpful. Gastric fistula management typically involves symptom control, and these patients oftentimes do have abdominal pain and weight regain. And these have to be appropriately managed. Now, the abdominal pain is often due to acid spilling into the jejunum or perhaps due to ulcer formation. It can also be due to the presence of foreign materials such as sutures or staples. So all of these should be addressed. When using proton pump inhibitors, it's important to use a soluble form of the medication or have them open the capsules so that it's adequately absorbed. You can also consider the use of sulforaphate to coat the area. We try to avoid use of narcotics, understanding that most of this discomfort and pain is either due to the acid or potentially foreign material that might be migrating into the lumen. Additionally, we do consider the potential for endoscopic or surgical revision in these patients. Now, this will be a focus of a separate video tip. However, patients with small fistula may certainly be amenable to endoscopic closure, whereas larger fistula or fistula that are complicated by a large marginal ulceration or stenosis of the gastroduodenal anastomosis may be better to move on to surgical revision earlier.
So, Dr. Thompson, how do you connect the pathophysiology of fistula and also ulcer disease in patients with Roux-en-Y gastric bypass?
Sure. So in gastric bypass anatomy, the rulin or loop of jejunum is sewn to the gastric pouch. And you're able to do this because the pouch produces very little acid. And the jejunum, as we recall, has very little defense against acid. It's not like the duodenum. It does not secrete bicarbonate. You don't have pancreatic juices going in there to neutralize acid. So it's particularly sensitive to acid. So when you have a gastrogastric fistula form, you have acid spilling from that gastric remnant into the gastric pouch and into the jejunum, and that tissue is sensitive to that acid exposure, and certainly ulcers are very common in that scenario.
Thank you. And one other question I had is, how do you explain weight regain with fistula present?
So that's a little more complicated because certainly when you have a gastrogastric fistula, some of the food is going to go the old way. So you are going to absorb more of those nutrients, and there certainly are several mechanisms of action, various gut hormones that are related to weight regain in that situation that are more complicated, and we don't have enough time to go into that. However, suffice it to say that you've kind of reversed the bypass partially, so calories are going down the old way and being better absorbed. But more than that, especially when you get ulceration, you can get a relative stenosis at the gastrojejunal anastomosis, really forcing more food that way, or they can start to have more pain, which leads them to start converting to soft calories. So now it's like a double hit. You have calories and food being absorbed better, and then they're eating foods that tend to require less breakdown before they can be absorbed. So it really is a setup for weight regain.
Thank you.